Welcome. My name is Herb with the Hard Sixers down in Whitney. This month we're going to be discussing TBI. On the agenda over the next 20 to 30 minutes will be introduction to TBI. We're going to go over management strategies, different injury types, patterns, signs and symptoms, followed up with a case study at the end. Thanks for tuning in. Up next, we're going to go into our introduction of what TBI is and go into its different classifications. So the agenda today for the next 20 to 30 minutes, we're going to be going over introduction. We're going to cover pathophysiology, clinical presentations, and also management of the TBI. So going straight into introduction, we're going to go into broad definitions, classifications, and also severity categories. So what is traumatic brain injury? TBI is generally defined as an alteration in brain function or any other evidence of brain pathology, generally caused by an external insult or force. Rolling right into different severities and also categories. There are two main categories, that being closed head injury, such as a blunt force, or open or penetrating head injury. Severity is usually considered mild, moderate to severe, and general clinical scales, such as the Glasgow Coma Scale, or what is utilized to actually define that TBI as mild, moderate, or severe. So why are we talking about TBI this month? TBI is just generally prevalent throughout the world. Recent figures show about 69 million new cases globally, and DFW is no different. There's significant TBIs that occur year-round, and I can say for most of us that it is a fairly common call to actually go on. So rolling into common causes and risk factors, falls being one of the major ones, again, mostly affecting the elderly and also young children. And this is due to either just environmental issues or due to unsteady gait, inability to actually ambulate correctly. The next very prevalent cause is motor vehicle collisions, different types of collisions, and usually boils down to either the severity of the collision or if people are not using the correct safety devices, restraints, seatbelts. Next common factor or cause is sports injuries, again in that like young adult or child athletes playing contact sports or not utilizing proper protective equipment. And then common risk factors generally being like recent or chronic alcohol consumption, prior TBI, and also just risky behaviors in any and all ages. So rolling right into pathophysiology and different types of TBI. So I'd like to discuss the Monro-Kelly Doctrine. Should be nothing new for you guys to hear, but it's always good to recover our bases. So what is the Monro-Kelly Doctrine? It states that the cranial vault is rigid, right? It's closed space. There are fixed volumes within this vault. Primarily made up of three main contributors, being the brain tissue, CSF, and blood. And so if there's an increase in volume of any one of these components, it requires a reciprocal change in the other components to keep the total volume to a constant. So if there's effect in edema or overproduction of CSF or introduction of more blood, it's going to affect the rest of the system. Rolling right into mechanisms of injury. There are two primary types, again being the primary injury and the secondary injury. Differences being your primary injury is generally your direct impact. Also your acceleration, deceleration injuries, shearing forces, or blast forces causing immediate brain tissue disruption. Also within this, it can be your penetrating trauma as well, such as skull fractures, causing direct insult to tissue, gunshot wounds, stab injuries. Your secondary injuries are generally your longer term or delayed effect, and also your biochemical events, such as inflammation, edema, ischemia, and also worsening brain damage over time. So your immediate effects due to any direct insult is actual physical damage to your neurons and blood vessels. And this will occur generally at the moment of injury and is typically irreversible. Your progressive effects something that we as EMS clinicians can actually affect, delay, or attempt to optimize are your biochemical cascades, and that will lead to further cellular dysfunctions and tissue loss. So going into some common direct injury patterns. So we have epidural hematomas, generally or commonly are arterial bleeds, and the most affected artery being your middle meningeal. You have your subarachnoid hemorrhage and also your cerebral contusions, your subdural hematomas, which are often venous bleeds from bridging veins, and also your DAI or your diffuse axonal injuries. And these can actually be primary or secondary. So rolling into DAI a little bit more, increase our understanding. So what is the mechanism of injury for your diffuse axonal injuries? They will generally occur due to significant shearing forces. These will cause widespread brain tissue damage, and this disrupts normal function significantly. As many as 80% of MVCs with induced TBIs will also include diffuse axonal injuries. Going into your secondary injury patterns involving diffuse axonal injury, these can generally induce or worsen DAI due to swelling and of detachment of axons. So there's also an impact on white matter. So DAI damages white matter, interrupting communication between your nerve cells and affecting your cognitive and physical abilities. And how do we diagnose and what are the outcomes of DAI? It's often diagnosed with MRI. CT generally lacks the ability to appropriately image it. And then generally result in coma or long-term impairment, which makes early detection critical. Rolling into our secondary brain injuries. These will generally develop in minutes to days following your primary insult. And this can be cerebral edema, ischemia or hypoxia, excitotoxicity, free radical formation, and blood-brain barrier disruptions, causing an increase in infections. Common injury patterns associated are swelling, causing herniation, delayed hemorrhage expansion, global hypoxic injury, and metabolic dysfunction. Going into those severity levels previously discussed. So what is mild, what's moderate, what's severe? Relying on the Glasgow Coma Scale, your mild TBIs are generally your GCS 13 to 15. You're going to have brief or no loss of consciousness, a return to normal generally in under 24 hours, and these will usually resolve without hospitalization or major management on our part. Moderate TBI is going to be your GCS of 9 through 12, loss of consciousness from anywhere from 30 minutes up to 24 hours. You will usually see a return to baseline in 1 to 7 days, but this may require intensive care, moderate or long-term risk.
Right.
Onto your severe TBI, GCS of 3 to 8, loss of consciousness in excess of 24 hours. Generally takes longer than 1 week for patients to return to baseline. High morbidity, mortality, and intensive rehab is needed for these patients. All right, we've discussed primary and secondary injuries, severity classifications. We're going to go right into clinical presentations and diagnoses. So for your primary injuries, you may still find those focal deficits, such as weakness, aphasia, cranial nerve deficits. For your epidural hematomas, your brief LOC followed by lucid intervals. You're going to have your rapid deterioration following. You may also have ipsilateral blown pupils. For your subdural hematomas, you'll often have that gradual decline in mentation against that brief or rapid decline with your epidural. And your subdurals are more common in your elderly patients, or especially patients that are also alcoholics or on blood thinners. With your DAI, you're going to have your coma without return to baseline or any return of consciousness. So with your secondary injury, there are patterns and signs and symptoms associated. And these will generally follow signs that you have a rise in intracranial pressure, right? So your ICP is increasing. Your early signs may be headache, you may have nausea, vomiting. You may also have some type of decline in mentation. And then Later in your life-threatening signs, it will be your Cushing's triad, right? Your hypertension, your bradycardia, and your irregular respirations. So let's discuss herniation and also herniation patterns. So there are different types. You can have your uncal herniation, your central, and your tonsillar. So your uncal herniation is when the uncus of the temporal lobe is displaced downward. For your central, it involves general downward displacement of the brainstem. You may also have herniation where brain tissue itself may herniate through a defect in the skull, which is common with severe penetrating head injuries. So let's discuss diagnostic tools in imaging. Imaging is the king, right? CT is generally your rapid first-line imaging to identify hemorrhage and fractures in the acute setting. You may also have to utilize MRI, especially to diagnose your DAI. And there's also DTI, which is diffuse tensor imaging, which is less commonly seen, at least while we're at the hospital. So let's talk about imaging and imaging findings in TBI. With your epidural hematoma, CT, you're going to have that biconvex, lens-shaped lesion that does not cross suture lines. The classic teaching, of course, harped on before, is you're going to have that brief lucid interval with these epidural hematomas. With your subdural hematomas, you're going to have that crescent shape, and these do cross suture lines, but generally do not cross from midline. You may have density changes over time, such as acute may appear hyperdense, chronic generally hypodense. Your subarachnoid hemorrhage will generally appear as blood, and the cisterns, it generally looks like white in the grooves. Moving on to your cerebral contusions, these appear as patchy hemorrhages, often in your frontal and temporal lobes, and these are more common in your coup contra coup injuries. With your diffuse axonal injuries, on CT, they may appear normal or as small punctate hemorrhages. Discussing MRI, which is more sensitive, they may find lesions in your corpus callosum, your brainstem, your gray-white junction. So increased ICP or herniation may appear as your midline shifts upon CT, compressed ventricles, and effaced basal cisterns. So some challenges involved in accurate diagnosis. Why is mild to moderate so difficult? It's because these are very non-specific symptoms. You're very.
Let's talk management strategies. Strategies for TBI management is generally going to follow most other known management strategies. Whether you're going to follow your March algorithm, your HABCs, your XABCs. A big thing we're going to want to focus on is airway management. That can be airway patency, airway protection. We're going to do ventilation management, try to optimize and correct any hypoxia, roll right into circulation. And then following that, we're going to want to trend ICP and then manage if herniation becomes apparent. Airway management strategies. TBI naturally has a low threshold for RSI. So being aggressive early and up front to maintain and prevent airway collapse is vital. So a single incident of hypoxia will cause a massive increase in your patient's mortality. So you want to avoid hypoxia at all costs. You're going to want to normalize your SpO2, preferably for several minutes prior to intubation if you are able. And then once you have a advanced airway, again, maintain north of 90%. You're going to want normal capnia, that 35 to 45 on that ETCO2. Always consider spinal immobilization. And then you're also going to want to utilize clear fluids for BP normalization prior to and during your intubation attempt. Going into circulation, there are also target goals. You're going to want a systolic blood pressure, preferably at 110 or higher. Or if you live in MAP, you're going to want a MAP of at least 80 to 85, in which we will also get into CPP shortly. Talking about elevated intracranial pressure, you're going to want to elevate the head of bed anywhere from 30 to 45 degrees as able. I know that's quite difficult within the cabin. Always consider hypertonic solutions. If this is an interfacility, The sending physician or receiving physician may order that, in which we can give or start in route. Common fluids you may see is 3%. You may also see as high as 23.5%. There also, I think, lives like at 7% out there, but that 3 or that 23.5 is going to be most common. General dosing for your 3%, usually about a 250 ml bolus over 10 to 20 minutes, and then 50 to 100 mLs per hour following. For your 23.5%, it's generally one large syringe given as a slow IV push bolus. They may offer Keppra, generally dosed at 1,500 milligrams for your average adult, or anywhere from 15 to 20 milligrams per kilo. You also might see mannitol. Mannitol is a somewhat difficult medication to carry on the transport side. It's apt to crystallize even at room temperatures. So you're going to want to make sure it's properly heated up and absent of crystals within the medication itself. Some facilities may administer TXA, 1 to 2 grams. There are some crash studies that so there is no benefit. There's some that do say there is a possible benefit. I think there's more studies coming out now and in the future that will kind of highlight whether or not TXA is actually worth it. The overall goal in our management is to preserve our cerebral perfusion pressures, our CPP. So how do we find CPP? That is MAP minus your ICP. Normal ICPs in your average adult is below 15. If you have evidence of increasing ICP, anything like severe or obvious injuries to the head, blown ipsilateral pupils, serial vomiting, it's safe to say your ICP is in excess of 20. So if you take your MAP, which might say 70 for other algorithms, that's appropriate. However, with presence of signs symptoms for ICP showing, just assume it's at 20. 70 minus 20 is 50. We want our cerebral perfusion pressures north of 60. So we're going to want to target that higher MAPs, generally 80 to 85, or if you're rolling off a systolic, at least a systolic of 110. Let's discuss multisystem trauma and head injury. In the presence of multisystem trauma, always consider exsanguination with low blood pressures, despite what that heart rate may be doing. Even if it's fast or slow, low blood pressure, evidence of bleeding, they're bleeding until proven otherwise. Follow blood administration protocols or your hypotensive protocols. There are multiple reasons a multisystem trauma patient with head injury may not follow your typical signs and symptoms if they are bleeding. These reasons can be medication related, taking beta blockers, medications that control blood pressure or heart rate, as well as Cushing's triad. If you believe they're bleeding in a multisystem trauma patient, always optimize with blood products first and target that higher MAP or that higher systolic blood pressure. Both NS and LR are crystalloids. However, LR is slightly more hypotonic, which can lead to additional edema or swelling. What we want is to remove fluid from that space. 0.9% normal saline or even plasmolite, if you encounter it, are both slightly more preferable than LR. The point is to preserve osmolarity and our CPP. We're going to avoid those hypotonic solutions and prevent those fluid shifts into tissue, causing that increased edema.
Rolling right into our case, I'm going to give you some dispatch information. It'll follow like a real call. I'll prompt things that should be prompted, and any questions, you just speak up, let me know what you want to hear, what you're looking for, what you might need. Cool. Sound good?
I like it.
All right, sweet. So you're riding out of Care Flight 4. You get dispatched to an NVC. Call notes state it's a heavy commercial vehicle, 1 patient.
Okay.
What are you thinking about just going to this? Just your general NVC rollover?
Yeah, I mean, my first question about any heavy vehicle is, I mean, when I don't have any other information on where they're just like, are they going to get trapped and stuff? Is there going to be prolonged extrication? Those kinds of things. Knowing that this is a TBI lecture, I'm going to guess that's not going to be a problem for me, but maybe it is. I don't know. Other considerations are just going to be my normal trauma workup once I get there of control major bleeding and ABCs.
Yeah, right on. Just keep stuck in that multi-system trauma mindset. You could be getting into anything. It might not just be isolated head injury. It could be a host of things. You might even have distracting injuries. So it's minor burns, fractures of the sort. What you may see, what you got in front of you is a 26-year-old male, unrestrained, extricated from the vehicle, no prolonged extrication. And they state he has a head injury to the right temporal area, was unconscious, did have a brief lucid period, and there was seen seizure activity in the ambulance lasting about 1 minute. Looking at the monitor, what you got, patient's already hypertensive, initial BP of 153/62, heart rate at 58, SpO2 90%, your vitals at 50.
You said 90%?
That's right.
Okay. Entitled to 50. Nice. And blood pressure one time 153 over what?
60.
60. Okay.
62.
Cool. So I'm in the ambulance now.
You're in the ambulance.
What's
you
he
get your
doing?
report.
I'm looking at him. What's he doing?
Patient's altered, not doing much, breathing on his own. They do have non-rebreather on. C-collar, not backboarded.
Okay.
Bandage on the head. Some blood showing, but it's not obviously like soaked through.
Okay.
And it does appear to have a possible right wrist injury. So just swollen, stuff like that. And then kind of looking around, not much.
Okay.
Not talking or really tracking your
Not verbal or anything, not interactive. Okay. Sounds good. That so, like I said, control major bleeding. You said that the head one's already wrapped and a little bit of strike through, but nothing crazy. Anything else? Neck down that I need to worry about?
No major hemorrhage found.
Okay.
No other major obvious injuries besides that right wrist.
Cool. What was I going to say? So the next thing is, like, obviously he's breathing spontaneously. He's not breathing super effectively if I have a stat of 90% and a total of 50. So next question is, like, make sure the airway's clear. Airway's clear.
Yep. Yeah. There's no blood, secretions, vomitus.
Cool. How do I remember sounds now?
You have equal chest rise fall, clear breath sounds.
So I have equal chest rise and fall and good breath sound, and he's still sat at 90%. We'll go ahead and if he's altered enough, we'll probably start assisting this guy's ventilation because he's on non-breather 15, so right. So that's not doing anything. All right, let's just guy's ventilation. I'll have an EMT or paramedic or my partner or myself. Somebody is going to back this guy.
Okay.
And then sounds like blood pressure's good, heart rate's good. 26 years old, 58. I was going to say 58 can be a normal heart rate for a 26-year-old, but probably not post-trauma. So again, this is kind of tying into that head injury that I'm visualizing there on the right side.
And they already reported that 1 minute of seizure activity prior to
1 minute seizure. And so I was hoping to be able to ask him if he has a history of seizure activity, but he's nonverbal.
Yep.
So we don't know. Cool. So it sounds like a head injury to me. Sounds like the next thing I'm going to do is BVM him with the intention to intubate him. Okay.
Sweet. Any other, things you want to look at, things you would consider?
No other trauma anywhere back here, no spine damage, nothing like no step-offs, nothing we can really determine from...
No step-off. There was no found issues with the C-spine. If you look at or ask about that bandage, they're going to say it appeared to be a depressed fracture.
Okay, gotcha. All right.
Any you concerned about pupils?
Oh, yes, thank you.
Yeah.
Can I look at his pupils?
Sure. So your right is 1 millimeter.
Okay.
Sluggish. Left is 6 millimeters sluggish.
Okay, so both reactive but very different. Alrighty. So I mean, yeah, that correlates very well with the right-sided head injury. Obviously, management for this guy is going to be kind of your standard pre-hospital head injury stuff. Plus or minus hypertonics, they're available to you. TXA, again, plus or minus, depending on which theory of medicine you subscribe to. The things that I can do for him are ventilate him appropriately, targeting an end-tidal of 35 with my BVMing. Even during the induction phase, like I know I'm going to have to intubate him here in a second, which I'll have to lay him flat to a degree. I'd like to do it and set him up if he's not backboarded to, like 30 degrees to promote venous drainage, just to decrease ICP as well as I can. Really, priority goals are blood pressure 153 right now is super great, not too high, not too low. Promote venous drainage, and then make sure he doesn't get a hypoxia.
Yeah, you're right on it. They've already got an IV going for him, so they have NS hooked up, maybe 250 cc's.
Okay.
No other meds given.
Cool. I see no reason to provide him more fluids right now.
Okay. Yeah. Cool. So you're getting stuck in, let's just say he's 90 kilos. Any medication considerations? What do you go with for that?
Obviously what we do here is fentanyl ketamine, which I think both are going to be perfectly reasonable for this gentleman. No concerns. I mean, there's always there's a relic of a dogma that fentanyl and ketamine could be problematic for ICP. Not concerned about that here. The only other option, I mean, if you had other drugs, that would help with that. Nothing crazy, nothing that I would prefer over fentanyl and ketamine. I don't think am I going crazy when I'm missing something?
No.
Okay.
No. Yeah, just those are probably the most common induction agents we'll find in the field here in DFW. You may find folks still utilizing lidocaine.
Yeah.
Like a school of thought thinking it's neuroprotective.
Right.
It doesn't increase like a massive, your MAP increasing, a sudden spike in your CPP.
Prevents that sympathetic nervous system response.
Right.
Yeah.
Right. And old school of thought with ketamine was it also created a large jump in your MAP, CPP. Studies show that that's generally a non-factor at this point. And even some protocols, some services may even describe like a higher dose of fentanyl. Of course, blood pressure can support it to prevent any sudden spikes like that. That's generally at your 2 to 3 mics per kilo. So generally higher. But again, ketamine's not really that active with your MAP in these cases, so it's kind of a non-issue.
Cool. Then 90 kilos, I'm going to go with 2 mg per kg, or 2 mics per kg of fentanyl, 2 mg per kg of ketamine, so 180 and 180, and then 2 mg per kg of sucks as well.
Sweet.
Which just between us, we might even be able to edit this out. I don't know. I wonder if like the stimulation of sucks can be problematic, can elevate ICP relative to like using Rockenbeck. Like I wonder if that like every 5 to 10 seconds can increase ICP if stimulating.
Yeah, I don't know.
I don't know either.
I imagine that there's probably a little jump in metabolism, like what the body's burning off.
Yeah.
But
I don't think so. I feel like we would know about it.
I doubt that, like major.
Yeah. All right. Cool. I wasn't thinking about it.
Yep. But other services pretty common also run into your rock. Some even carry back.
Yeah.
But for our case here at CareFlight, we use the sucks.
Sweet.
Just a kind of aggressive airway control, going back into that low threshold for RSI.
Is BVMing him being successful?
Yes.
Am I getting stats up?
Yep.
Tidal down? He's cooperating?
Yep. And tidal slowly tapping down. SpO2 in the mid-90s. No prior.
Oh, I'm sorry. Did they have to break the seizure with anything?
Nope.
Okay.
They did not administer anything. Nope.
Okay.
They just 1 minute. By the time we were able to get anything going, stopped.
Cool.
Just kept rolling.
Awesome.
So with airway control, ventilation management, are we concerned about ICP and herniation?
He's bradycardic with a fairly wide pulse pressure. He's not super hypertensive. I wouldn't say he's like full blown meeting the triad yet, but I'd say he's pretty much kind of right there of kind of showing just the clinical signs that I can find or that I can assess for herniation. I mean, obviously he has the blown pupils, or not blown, but the different pupils, right? Yeah. So clearly a head injury, monitoring his vital signs to watch for worsening bradycardia or anything like that. There's no harm, again, because we're not using lidocaine, there's no harm also in maybe having atropine ready, depending on how low his heart rate gets during the intubation process, because of course that stimulation of the valvular area can also induce a little bit of bradycardia momentarily. Other than that, I'd be concerned for herniation here. If we, there is a way to ultrasound, the optic nerve sheath diameter to actually look behind the globe of the eye and look at how wide that optic nerve sheath is. Greater than 5 millimeters is indicative of an ICP of 20 or more. And it's not like, 6 millimeters means 25 and 7 millimeters means 30. It just means 5 millimeters, at least an ICP of 20. That's pretty much all you can get from that. So it'd be a nice diagnostic tool to use, but not something we routinely do.
Gotcha. Yeah, right along with you. Say with the current signs, symptoms, and vitals. Starting to get into that triad. Probably looking at either early stage of herniation and ICP of at least 20 is probably safe to say it's probably elevated above that. Which is again another thing to always consider your systolic blood pressures, your MAPs. For this guy, he's hypertensive instead of right in the line, so there's at least circulation wise, we're not towing the line. But moving on, you've kind of already hit some of the things for herniation management. You've already talked about elevating the head, which can be sometimes difficult in the aircraft. Just do what you can. 30 to 45% is preferred. If you have to stick like blankets or equipment roll behind them, just to elevate a little bit more.
say it's worthwhile. How do you want to target CO2 for this guy?
I mean, obviously just controlling minute ventilation with, on the ventilator, it'd be a lot easier targeting minute ventilation. BVMing him, I mean, get him down to 30, 35, ideally. Like at 35 would be ideal. 30 to 35 is acceptable. Definitely no lower than that. We're starting to swing back away from aggressive hyperventilation, like extremely aggressive hyperventilation, right, to just targeting just that low and normal, right, 35. Because you don't want CO2 in the brain vasodilating. I mean, in theory, that lowers your blood pressure. It's like, oh, it makes the bleeding worse. But back to what you talked about earlier in this lecture of Monro-Kelly Doctrine, by dilating the vessels, you actually allow more blood to enter the brain because you have to fill a larger hose. So that actually will increase ICP. So you actually want to constrict the blood vessels a little bit, but not so much so that now there's not enough blood flow or what have you.
Right.
So, and that's what happens if you hyperventilate someone too aggressively. The blood vessels constrict too much, and that can cause its own problems. So 35 kind of like spot where you want to be.
Yeah, right on. Additional vitals, general increase in your blood pressure, 162 over 50, heart rate's at 53, your respiratories are corrected, whatever you're bagging or what you set the ventilator at.
Can I be intubated now?
Yeah, cool. Yeah, be intubated. Successful.
Awesome.
SpO2 post-intubation, let's say 95%. And since you've taken over ventilations, have a gradual decrease in your CO2. So say we're just down to 40 right now, but you know what you're trying to get down to, you know your goal. Since you did mention it earlier about fluid choices, hypertonic, crystalloid, let's get into that a little bit. So I know in the lecture we did slightly discuss avoiding hypertonic solutions. Again, like 0.45% normal saline. Again, just we're trying to optimize that osmolarity, trying to keep fluid from re-entering that brain tissue, that space, because we want to draw it out. Normal saline's kind of the most common out there. It's the best option. For our inner facilities, you may encounter that 3% to 23.5%. So I would say that shouldn't be out of left field for an IFT or uncommon. I've seen it around. Mannitol. Do you know any, transport considerations surrounding mannitol?
Yeah, I mean, just crystallize it. Like that vial, you shake it even ever so slightly. And I mean, if people hate transporting propofol in a helicopter because, it's the class 5 when it came with the air out, mannitol, you're going to have the issue with getting the air out still, and it's going to just crystallize and shake up everywhere on you. And it'll basically just turn white and almost look like propofol. Get it on you, it's really sticky. So that's the major transport consideration, at least as far as just like the operational logistics of it, is it's just really annoying. You have to be very sensitive and gentle with it. The way it works, it's an osmotic diuretic, and so it's just going to pull fluid off, and it's going to actually pull, instead of pulling fluid off, it's going to pull solutes off, and then the fluid's going to fall out.
I gotcha. Yeah, and it's also temperature sensitive, so even at room temperature, it'll start to crystallize. So if it's handed to you and it's in the colder months, definitely be cautious with it. Heat it up, stick it in your pocket, or throw it in the blood warmer, or throw it in the fluid warmer for a short time if you intend on giving it during transport. And then rolling into little considerations with our hypertonic or crystalloid. Again, if there's a risk that this patient is even possibly exsanguinating, our blood pressure's low, always err on the side of their bleeding to death. I'd always go either trauma. Hit them with the blood if they meet our MSI criteria. Try to optimize with our clear fluids. Just understand our hypertonics may actually have may cause a decrease in blood pressure when it's first administered. You'll generally have a slight relaxation of your vessels with it. So just be cautious of that. Then moving on down, what are your thoughts on seizure prophylactic, like Keppra or anything like that?
Oh yeah, I mean, if he's already had a seizure and I had Keppra with me, or if I was picking this guy up from a smaller hospital and he already seized, I'd for sure be asking for a grade 2 of Keppra, 100%. If I don't have it, if they don't have it, he's going to get it when he gets to wherever he's going. For sure, like Keppra is going to get put on board with this gentleman. There's no harm with this guy. I have no qualms about using even Versed for post-intubation sedation. because why not? He's young, he's healthy, he presumably has a healthy heart. I can ultrasound his heart and see if it's healthy or not, but that's extra. I'm not going to do that. I can assume this guy has a healthy heart. He can tolerate benzodiazepines. It's not going to lose cardiac output from that. It'll sedate him. It'll keep the blood pressure hopefully within range, and then hopefully it'll suture prophylaxis as well.
Right.
Or at least I have it drawn up. If he does see it, I can just draw it and push it.
Yep. Standard dosing for that.
Yeah.
Yeah, I mean, you're hitting it. Management is nothing crazy for these guys. It's just being cautious for goals. Again, like you said, just hit that blood pressure. We know our minimums for a scene call. We're not going to be trying to reduce or control it down. That'll be for the hospital to determine. I wouldn't be shocked even with a traumatic or open head injury if it's an interfacility to have the patient on some kind of blood pressure control, if that's what's sending or receiving.
Yeah.
So I wouldn't be surprised if you come across that.
What was I going to say? One other thing. Oh, and I just want to say, like, the reason I asked if they had to break this guy's seizure or not. Let's say it's an interfacility, for example, where they had this guy for hours and he seized several times, and they kept giving Ativan Reset, a bunch of benzos, and somehow in those multiple hours chose not to intubate him. When I get there and I like to intubate him, just everyone remember that opioids and benzos can have a very synergistic potentiating effect. So if they had been giving him a bunch of benzos to break his seizures, I would just decrease my opioid dosing. I would do like 0.5 to 1, like sprinkling your fentanyl. Continue my ketamine and my sucks at the same doses, obviously, but just, understanding he has a bunch of benzos on board, I don't need as much opioid.
You don't want to push them over.
Yeah, exactly.
It's smart. Yeah. Like discussed earlier, single incidence hypoxia, single incidence of hyperperfusion, very bad for these guys. Just a massive increase in mortality.
Cool.
Any closing thoughts?
Like, what's the origin story of this case study?
Happens all the time. Really, an armored vehicle rollover.
In Syria?
No, this is a stateside, but
Training?
yeah.
Hell yeah.
Ejected from a turret.
Oh.
Yeah.
Yeah, that tracks.
No bueno.
No. How's he doing?
Mm.
All right, cool. You did your job.
This is years old.
Yeah.
All right. Thanks.
Cool. Thanks, everybody.
All right, y'all. This is the end of TBI. We've discussed what TBI is, different injuries, different severities, management strategies, focusing on airway protection, ventilation management, and blood pressure management. We closed it off with a case study, and I hope you all got something out of it. Thank you.